So now I would like to ask our second speaker, my friend, Professor Paweł Michalek, to present his 1-year experience with UE Video Stylet. Paweł, the floor is yours.
Thomas, thank you very much for introducing me. I'm just starting to share my presentation. Can everybody see the first slide? Okay. So I would like to express my thanks to Thomas for inviting me to this interesting webinar. It's a great opportunity to meet my friends again, my friends from EMS, Max Orbello and Tomasz Gashiński, and to share our experience with one of, I would say, very good products of UE with the auditorium. So I would like to declare my conflict of interest. So I've received some devices for free, mainly video laryngeal masks from UE Medical, and I've got, or I will get, as well reimbursements for this lecture. First, some things about my person. So I work in the second biggest hospital in the Czech Republic, which is located on the Charles Square in the center of Prague. This hospital is very old. The first buildings were built in the 15th century. It's quite huge, so it's spread out through the center of Prague, and we have almost 50 theaters running every day and 5 intensive care units. My clinical work is mainly cardiothoracic and vascular perioperative care, with a special interest in airway management in all categories, including neonates. As well, I was a lead consultant for airway management for 6 years in the United Kingdom in a big regional teaching hospital, and I am involved as well with board of directors of European Airway Management Society. In this lecture, I would like to share my experience with UE Video Stylet. So the idea of video stylets, it's not very, very young. So the first stylets were invented in early 17th of the last century when American otolaryngologist Katz and Bartzi invented straight video stylet connected to the big monitor. Because this straight video stylet had quite a significant percentage of failures. In following years, curved stylets were invented. The most famous of them was Bonfil stylet. You can see it here on the screen, and this Bonfil stylet actually allowed to intubate even the most difficult patients, such as Pierre Robin sequences in pediatric patients. Many stylets have been invented since that, and one of the newest one is UE Scope from UE Medical Company. So if you can see this type of stylet, it's a rigid with a special bend shape at the tip of the stylet. It has very good HD monitor integrated to the device. The monitor can be positioned in different positions, so you can intubate the patient from the back, from the front, from the side. The monitor allows as well to record the still images and videos, as you will see in following slides. And what is quite interesting here is that part of the device. It's a multifunctional connector allowing oxygenation, suctioning of the saliva or blood, and as well as application of local anesthetic solution using the spray-as-you-go method. The first report on this device was published in 2015 in China. And on this slide, you can see the promo of this device. What is quite important is that the tip of the stylet should be hidden inside the tracheal tube just to protect from the damage of vocal cords and trachea. You can intubate your patient using the midline approach, or you can tube them as well using the retromolar approach, which is quite nice. So this is your view, and once getting this view close to the cords, you can railroad your tube down to the trachea. So what about this UE stylet? We know that all boys love their toys, and new toys are better than old toys. Some toys are very good, some toys are bad, some toys are even dangerous. I would say that this toy is quite useful, and you can tube your patients, you can see it on the mannequin here, using different techniques. So this is midline approach. First one, you should localize the epiglottis and then the vocal cords. What is quite important with this device, it's not to insert the device down to trachea. You should stop just in front of the vocal cords and then railroad your tube down to the trachea. You can use as well your retromolar technique. So it's very useful in the patients with limited mouth opening. You insert it behind the molars from left or right side, then turn it over down in the oropharynx, and then after location of the cords, you download the tube to the trachea again. Here you can see the functions of the connector. So on the first slides, on the left side of the screen, you can see connection to the oxygen to the port. So you can deliver oxygen from your anesthetic machine, and actually it helps you to improve the oxygenation in spontaneously breathing patient. On the second slide, you can see the suction device attached to the multifunctional port. So if your patient are salivated, as you will see on one of the videos in this presentation, so you can suction everything from the oropharynx in order to improve your view. And the last one, if you adjust a wee bit your tubing system, you can use this connector for local anesthesia with the method spray as you go, similar to methods used in fiber optic bronchoscopy. So you can see the application of the local anesthetics from the side, visualizing of epiglottis, now visualizing of the vocal cords, spraying, and then very easy insertion of the tracheal tube down to the trachea. So we have used this device for more than 1 year. I would like to present our shared experience with Professor Tomasz Gasiński from Łódź in Poland. So we have intubated more than 70 patients. We use that in all types of patients. So it was in routine patients instead of Macintosh or GlideScope video laryngoscope, but it has been as well in patients with predicted or known difficult airways. So, and we use that for both awake and asleep intubation. So this is big advantage that you can use it as a plan B, but as a plan A as well. To be absolutely honest, we have had 3% of failure rates. So one failed patients in Thomas hospital and 2 failed patients in our hospital. And these failures were associated mainly with uncooperative patients or with too much secretions in the airway. I would like to overview 4 scenarios of our patients. So the first one was a middle-aged female scheduled for elective abdominal surgery procedure. That lady had a previous history of failed conventional intubation with both Macintosh laryngoscope and video laryngoscope. It was during her cesarean section, so that time the airway were secured using the laryngeal mask airway and then retrograde intubation with the wire. On examination, she had Mallampati 4, limited mouth opening, very short neck, very fixed neck, so in flexion, so you can see it here on the left side slides. And she was very cooperative lady. She was very scared of failed airway management during her procedure. So we all agreed for plan A, awake intubation with UE Video Stylet. So you can see it here on this screen. So a lot of saliva. We use midline approach, so you can see epiglottis located here. Then from the side, we passed the epiglottis and then very easily located the laryngeal entry. And once getting close to the cord, so you can see the cords moving here. Here you can spray them, and then at this moment, the tracheal tube is inserted into the trachea. The second case was an Ukrainian patient admitted to our hospital for a complex repair of the ascending aorta and aortic root, a so-called David procedure. He had a language barrier, so he was very tall, more than 2 meters height, and he had several predictors of difficult airway. So our plan was to intubate him again awake, but because of limited cooperation and language barrier, we weren't able to proceed with awake intubation. So you can see this gentleman here, it's very tall, very long theromental distance. And so that's why, because he had very low prediction of difficult mask ventilation, so we proceeded with a sleep UE Stylet intubation. So you can see the live image here. So this is his cleft palate. You can see very nice view of the epiglottis and relaxed cords. So this is live demonstration. So you can see that the entire tracheal intubation lasted less than 1 minute. Very good view to the cords, insertion of tracheal tube again. The third case was a morbidly obese patient. So you can see her on this slide, on the left side. So she was elderly. She was indicated for oncological complex procedure. She was morbidly obese with COPD, obstructive sleep apnea, coronary artery disease, and pulmonary hypertension. Her MPAP was 65, and she was classified as ASA4 patient. So that lady had combined predictors for difficult anatomical and physiological airway. She agreed with hesitation with the plan A, awake intubation with UE Video Stylet. And it was quite difficult because there was a limited cooperation, a lot of saliva. She was sedated with dexmedetomidine. And you can see the view was very bad in the first instance. So there was a lot of saliva, very poor orientation. And so we had to sag her out twice. And this is the section, the patient in semi-sitting position. And this is the second attempt. So you can see her showing her tongue. And the view again, suboptimal or anatomical orientation not great. But at the end, within roughly 3 minutes, we succeeded. So we were able to localize the vocal cords and tracheal inlet. And after spraying the cords, we were able to intubate the patient. You can see still a lot of saliva, and now we are close to the vocal cords. And this is tracheal intubation. The last slide about our scenarios comes from Professor Gashinsky. So you can see on the left side, this is a patient with unexpected difficult intubation. So on the left bottom image, you can see McGrath view. So you cannot see grade 4 larynx according to Cormac-Lehane. So you cannot see any clear structures. And on the next image, you can see very good view with UE Video Stylet. The second patient in the middle is morbidly obese, so you can see that Professor Gashinsky is helping himself with Macintosh blade, so you can help himself with a videolaryngoscope as well. And on the third patient is a complex oncological patient after mandibular resection and after radiotherapy with very difficult airway, intubated again very quickly and easily with UE Video Stylet. What about the evidence behind this? So this is the first publication from 2015 showing that video stylets have less hemodynamic response than classical Macintosh blade. Then you can see another publications showing the efficacy of video stylets in predicted difficult airway. And you can use UE Video Stylet even for double lumen tube intubation and positioning. So you can see that in comparison with a standard laryngoscope, the intubation time is shorter, but on the other hand, the total success rate is lower and success rate on the first attempt is lower as well. The authors didn't state what was the learning curve and preparation for using of this new device. On this slide, I would like to compare 3 devices used for known or predicted difficult airway, and it's video stylet, video laryngoscope, and flexible endoscope. So video stylet may be used for awake and asleep. Difficult airway management is the same with video laryngoscope. With flexible endoscope, it's more difficult because intubation takes longer than these previous 2 methods. So it should be used mainly for awake intubation, and when asleep, it should be inserted through the supraglottic airway device. Video stylet and video laryngoscopes can be used only for oral route. Although there have been 2 publications of using of video stylet through the nose, but I personally feel that this approach is quite traumatic. The advantage is that with the first 2 methods, you can place the tracheal tube under direct vision into trachea. With flexible endoscopy, there is a trouble that your tip of the endoscope can be very safely close to the main carina, but your tube can become stuck on the arytenoids, and you can have troubles advancing the tube to the trachea. What about the learning curves? While learning curve with the laryngoscope is quite short, learning curve with UE stylet is intermediate. So you can see on the screen on the right side that our trainees practice on the mannequins quite often. The longest learning curve is with the flexible endoscope. Regarding the mouth opening, for video stylet and for the endoscope, you need very, very small mouth opening, actually the small opening close to the diameter of the endotracheal tube. And with the video stylet, you can even have less mouth opening because you can use a retromolar route for your intubation. So regarding the equipment, a video stylet is reusable as well as video laryngoscopes, but video laryngoscopes have usually single-use blades. Flexible endoscopes, you can have both single-use and reinforced versions. What about the potential to do damage? So video stylet is very, very difficult to damage in comparison mainly with the flexible endoscopes. I'm getting close to the end of my presentations, and as well as my friend Max Sorbello, I would like to invite you all airway enthusiasts to EAC 2024, which will be held in September in Istanbul, the capital of Turkey. And as you can see on the left side screen, these are the pictures of Max, myself, Anil Patel, and Tolga Sarasoglu, the current president of EMS, in the previous 2022 EAC in Antalya. And that's the end of my presentation. And airway management is evolving, so it's the same as evolution of the anesthetist. So you can see the anesthetist 2000 years before the Christ, moving through the ether and chloroform, through the Macintosh blade, reading the papers to the artificial intelligence in the middle of 21st century. Thank you for attention.